Good morning. So sorry I had to leave a little bit early, but I was asked to talk about how to assess the ACL, MCL in clinic. So here are my slides. No relevant disclosures at all. So obviously the MCL is the most frequently injured ligament, and it gets very tricky when ACL and MCL are injured in combination. We're dealing mostly with grade 1 or 2 injuries, and I think most of us will leave those alone. And the question is, for those few that are being grade 3 injuries, what are we doing for those cases? I do want to just point out real quick, this is old classic literature, but it's from Pittsburgh, from Xavier Wu, from the early 2000s. And based on the study in goats, we know that when the ACL is torn, the MCL receives more strain and vice versa. So we really need to be careful, especially when we're talking about football players. And so this is the classic history, and I think history is really most important. So 90% of what I do in clinic is history, and then of course, specifically with the MCL, you need your physical examination. And thus, this here is a very easy case because it's a huge instability and there's no question that you will fix this, whether you use an allograft, autograft, or synthetic. But the comparison in the exam is to the contralateral side always, and less than 5 millimeters of opening is a grade 1, 5 to 10 is grade 2, and greater 10 is grade 3. And I like to hold the leg like you've seen this, slightly over the edge of the table. I cradle the hamstrings with my opposite hand, in this case the left hand, and then I do my stress by pulling on the ankle with the right hand. And I do use stress images. So here again is the classification, 5 to 10, and greater 10, and there's also no endpoint in the case I just showed you. Here are the treatment options, again for the grade 1s and 2s, non-operative treatment, stable injuries, even if on MRI, maybe a grade 3 injury is there, the clinical exam overrules the MRI, and it'll be called a stable injury and a likely treated non-op. Final decision, examination under anesthesia. The algorithm goes like this. So healing response, 2 to 6 weeks in the brace, depending on the severity of the injury. And then for ACL plus MCL, maybe grade 3 injury, 6 weeks in the brace. I lock the first couple of weeks in extension. You can do EUA and stress radiographs. And in my case, I do not use hamstring grafts when I have a high-grade MCL injury. In the multi-ligament, in the acute setting, I try to repair. In the chronic, there's reconstruction. So operative management is reserved for avulsions, persistent grade 3s, combined lesions with great instability, multi-ligaments, and the so-called steno lesions. So I do want to talk real brief about anteromedial rotatory instability. It's a bit more subtle and probably more important and probably what you want to hear from me anyway. So it's a drawer with the foot in external rotation, and usually you don't have a lot of opening on stress radiographs. And so this data here from Andy Williams showed that the deep MCL is the largest medial restraint. For the valgus load, of course, it's the superficial MCL. And you have persistent AMRI as a problem if there's inadequate superficial MCL or deep MCL healing. So you gotta assess this very importantly. And I think there's a nice little table from Christian Fink and Mirko Herbert just going through these stages, but this grade 1 is really the most tricky one because once you have a lot of valgus opening, it's very easy to assess. But you don't have a lot of valgus opening and just the deep MCL is injured, but you have increased external rotation, and the football players will not like this. So he can do this, for example, this flat tendon graft. This is Christian's technique, but there are many other techniques as well, and it closely resembles the fiber orientation of both the AML and the superficial MCL. So here are some considerations for surgery, and I'm just going to end this by showing you 2 quick cases. This is a case of a defensive lineman, very big, more than 100 kilo football player. He had really a grade 3 MCL injury, if you will. The superficial MCL is off, and no other injuries. And I told him, you must have surgery, and he said, absolutely not. I don't want this. So he was in a brace for 6 weeks. Close kinetic chain exercises, as you see on the left, and on the right, and he healed this actually very well, and this is a nice, easy way to do this. This is a subtle case. This is a 23-year-old soccer player, and they've had anterior medial knee pain for a long time. They had an MCL injury, they recall, 5 years ago, but never treated, really either with a brace or surgically. When they came to me, they had very good range of motion, but they had a painful valgus at extension and at 30 degrees, with not much opening. So I took them to stress radiographs, and it's maybe 1.5 millimeters more opening, but they had increased external rotation. And so you can see, again, no big drive-through on the X-ray. I think Al Getgood, you in the audience, you were in this case with me. But then we did a synthetic graft. You can see this on the right picture to fix the superficial and the deep MCL. And this patient did very well with this. Good outcome can be achieved. So in summary, grade 1 and 2 MCLs are non-operative. Grade 3 is the in-between, and it may require surgical management. Be suspicious for other injuries. The MCL is rarely isolated. Untreated valgus laxity will lead to overload of the cruciates. And medial instability is a bit difficult to quantify, so EUA is very important, as well as fluoroscopy. Be careful with the AMRI. And the surgical timing is a balance between stability and stiffness. And we're currently doing the STAR trial to give you a bit more data on what the best timing is. So with that, thank you very much, and I see you all soon.